and is now hemodynamically stable. The ventilator, oh, I know what's happening. In order to get, let me explain this really quick. There's something new with the college now. All of my information gets stored on OneDrive. Probably Nick knows what that means. Instead of it being stored at Broward College, they now store it on a Microsoft website. So in order for me to get to all of my lectures, I have to go through my email to get to OneDrive. So that must mean email is on, and as the emails come through, it's giving us a bong. All right, so we got a patient with normal lungs, CHF. They're hemodynamically stable, so they fixed the congestive heart failure. The ventilator settings, they're full support, assist control mode, rate is 10 per minute, tidal volume 650 ml, 40% FiO2, PEEP is 5. The ABGs are 7.49 pH, the PCO2 is 48, PaO2 108 with a bicarb of 29 and a +7 base. Is the patient a candidate for weaning?
We have to correct the blood gas.
If we don't correct the blood gas, do you see a problem with weaning a patient with this blood gas?
Yeah, because their CO2 is high.
Why do you think the CO2 is high?
Trying to correct the alkalosis.
Very good. Yeah, so there's a obvious metabolic alkalosis going on, and metabolic alkalosis will suppress breathing. Not until CO2s are like 70 or 80, but up to 50 torr. So when you have a metabolic alkalosis, it will prevent the patient from breathing their normal amount. So you do have to correct the metabolic alkalosis first before weaning. So correct the metabolic alkalosis first before attempting to wean. Do you remember the main cause for seeing metabolic alkalosis in the ICU patients?
Alkalosis? Couldn't. Diarrhea? Yeah.
That's a cause for metabolic acidosis,
Yeah, that's
because diarrhea has a lot of bicarbonate in
it's
it.
a hyponatremia.
You're almost there. Hypokalemia, low potassium.
Yeah.
Yeah, with low potassium, it causes a metabolic alkalosis. I guess the kidneys have to get rid of something. So they hang on to potassium and they get rid of hydrogen ions. So low potassium is like the most common reason you're going to see metabolic alkalosis in your blood gases. So check your potassium level. There was a court case several years ago where it was a patient that was extubated with a metabolic alkalosis, didn't do well. Soon after extubation, she coded, was not successfully resuscitated, and then of course the family sues and they were asking for an expert witness. So they sent me the case and asked if I would do a deposition, and it never got to that because I guess everybody settled out of court. But this was the patient's blood gas and ventilator settings prior to being extubated. So yeah, make sure that you're aware of that. And you don't think it falls on your shoulders. Like, oh, well, the physician said extubate, they wrote extubate, so I'm just following physician orders. So then you're asked, well, what about your level of training? Aren't you taught that metabolic alkalosis can suppress breathing? And why would you even start to wean and extubate somebody who has metabolic alkalosis? So they could point the finger at you. So you want to make sure that you check that prior to weaning and extubating. All right, why is this patient breathing so fast? A post-op patient from a lung resection with a history of renal failure and diabetes, that's a lot of comorbidities there, woo, weighs 65 kilograms. The fluid status shows 4,800 ml input, 3,700 ml output. Breath sounds reveal rails halfway up on both sides. Do you see what's happening here? There's so much fluid retention that it's actually going into the interstitial spaces of the lungs, and then the fluid actually is going into the alveoli. And when the patient breathes, you can hear that fluid rattling in the alveoli, or crackling, or rattling, or whatever you want to call it. So that rails halfway up the chest, I guess. Ventilator settings are assist control mode. The rate is 10 breaths per minute. Tidal volume 700 ml. FiO2 is 0.4. PEEP, 5 centimeters of water. The total respiratory rate is 37 per minute. Saturation, 97%. And looking at the blood gas, 7.31 pH. PCO2 is 22. PaO2 is 82. Bicarbonate is 14 with a base deficit -9.
Metabolic
So there's a metabolic acidosis. And how do you explain the low CO2 and the tachypnea? Or the hyper, is it considered hyperventilation if we have an acidotic pH? No, it's not. It's only hyperventilation if we have a low CO2 and an alkalotic pH. Yeah, so they're trying to compensate for the acidosis, right? By blowing off a lot of CO2. So, and yet the pH is still 7.31. How would you treat this patient? And you can think outside of ventilator changes, by the way. All right, so bicarbonate is needed?
Give a bicarb, maybe, for kidney failure, so
They need
they'll need to be
Lasix or something.
diuresed.
All right, so either dialysis or if they're still responding to
Or if
Lasix.
they're responding to the drugs, then give them.
I mean, couldn't the diuresing bring them to that?
The
Maybe
diuresing
too
what?
much diuresing, and that's why the bicarb is so low? Could that happen?
To lower the bicarbonate by diuresing too much?
Yeah, like does that? Like if you diurese them too much, it can
I don't
cause
think
them
it'll be
to lose.
Oh, is that because you cause dehydration and all the metabolites increase in value?
Yeah,
or-
because if you're diuresing, you're getting rid of the potassium. Well, no, I just got no thoughts in my head. But I would think diuresing would get rid of the bicarbs. So excessive diuresing would have to stop.
Would you want, I know they need bicarb, but since they already have extra fluid, you're giving more fluid with the bicarb. Is that bad? Would it do more harm than good?
If you give bicarbonate to a patient that has a good blood pressure, then it's not going to have negative effects on the body. If they don't have a good blood pressure, like they're coding, and you give sodium bicarbonate, it diffuses in, the CO2 will diffuse into the brain. But if they've got a good blood pressure, the CO2 will just come back to the lungs and it'll get exhaled. Yeah, so when a patient has renal failure, they can't clear any protein breakdown from their blood. And protein breakdown results in acids being formed. So you've got all these acids building up in the blood. And that's what causes the metabolic acidosis with renal failure. So do they need some bicarbonate? Yes, and they also need dialysis to get rid of the fluid and to straighten out that the acidosis by getting rid of the metabolites in the blood. Did you write the answer to that, why they're breathing so fast? To compensate for the metabolic acidosis? Does fluid retention affect oxygenation and ventilation? So you're caring for a motor vehicle accident patient who has sustained rib fractures on the right, 8 of them, 2 on the left. It is his second day in the ICU. His input is 9,500 ml, output 2,500 ml. The patient is intubated, and the ventilator settings are PRV CMO with a rate of 12 per minute, a tidal volume 500 ml, FiO2 is 0.5, and PEEP is 5. Patient weighs 104 kilograms. We're not given a height though. The patient is being infused with a neuromuscular blocking agent, Norcuron. And these are the blood gases. 7.20 pH, CO2 is 68, PaO2 is 56, bicarb is 20 with a -7 base deficit. So I think all of this fluid retention of 7 liters, how can you, I wonder how realistic this is.
A little complicated.
Yeah, where'd you get this? Did you make it up?
This one I took from, I don't want to say anything bad about anybody, so I'm not going to tell you. But yeah, I was given this by another respiratory therapist.
Wow.
So 7-liter fluid retention. It's going to go into the lungs because that's one of the places that fluid goes.
So that affects the oxygenation and ventilation.
Yes.
And this ABG is a metabolic and respiratory issue.
Acidosis.
Or acidosis, yeah.
Yes.
So,
Yeah, so with a PaO2 of 56, that's a low amount of oxygen in the arterial blood. The setting, see, even the SAT wouldn't be 93% with a 56 PaO2.
yeah. Be like in the 80s. Yeah. It would be like
Yeah,
80.
it'd be like 88 or 89 with a 56 PaO2. So the point is, with low oxygen going to the tissues will start producing lactic acid because they're not getting enough oxygen delivery. So you've got low oxygen, lactic acid is going to eat up the bicarbonate, so it's dropping the bicarbonate. All that fluid is preventing good ventilation. All right, so what is your recommendation for making everything better? Diurese, okay. Do you think it's good to increase the rate and increase the minute ventilation while you're waiting for the diuretic to take effect?
No.
Yeah, it's arbitrary. I mean, it's, one person says, yes, go ahead and change your settings. The other one says, no, the problem is all the fluid, get rid of the fluid and then ventilation will be better. So I guess if that's quick, you give some Lasix and then 30 minutes later, you've diuresed and now everything's better.
Could they increase his respiratory rate too? Because he's only on a rate of 12.
Yeah, and this person is, they can't breathe faster to blow off CO2 because their muscle paralytic is on board? Yes. So yes, you could increase the rate until the patient has been diuresed, and then you would wean the rate.
Does this patient possibly have a pneumothorax? Because,
See, with a pneumothorax, we would expect high ventilating pressures. Does it give us that? No.
Well, wouldn't you see a higher?
I'm only seeing it because he had a, broken rib and possibly lung contusion.
Yeah. Rib fractures.
Yeah, so when the ribs break, they're pushed into the lung tissue, and it's a sharp piece of bone,
Yeah.
and it typically does penetrate the lung.
chest.
Yeah, so I think we need a different scenario because there's a lot of holes in this one. So it should tell us that, you know, we've already have chest tubes in place. Just to let you notice that everything's okay, focus on the problem that we've got, a 7-liter fluid retention. Yeah, but I can see how you were thinking, well, pneumothorax, we've got all these fractured ribs, there's no mention of chest tubes. There's no mention of high airway pressures or chest x-ray, nothing. I guess we may have to make some assumptions. It's the second day in the ICU, so maybe all of that was taken care of. All right, any more questions on this? Did you write down your recommendations?
Would you increase the FiO2?
Yeah, until you've diuresed. Assuming that the SATs are really 88 and not 93%. If they were 93%, no. But yeah, if they were actually a 56 PaO2 and 88 saturation, yes.
You'd expect a 93% from the whole scenario anyways. It's hard to imagine their saturation being.
Yes, I agree. SOB in the ER. A morbidly obese patient is in the emergency room suffering from severe shortness of breath. She is currently on a 1.5-liter nasal cannula, is diaphoretic, using accessory muscles to breathe, and is wheezing. The patient is very anxious and states that she can't breathe and doesn't know what she did with her inhaler. ABGs show a pulse ox sat of 87%, the pH 7.35, PaCO2 is 86 torr, PaO2 44, bicarbonate 40 milliequivalents per liter with a plus 13 base. What would you do for this patient?
To increase more.
She needs more oxygen.
All right, so she needs more oxygen.
She's not doing it.
Shrimp.
Venting.
That would
Increase the liters.
increase, exceed.
All right, does anybody think a non-rebreather mask is in store for this lady?
A non-rebreather?
Yeah.
Yeah, because she.
Give her 100%. She's really struggling here. Don't fall for my tricks. What would happen if you put this lady on a non-rebreather mask?
She's
Most likely a CO2 retainer with an 86. Now that's her normal CO2,
you knock her.
right? Her pH is 7.35. Her CO2 is always 86. So a CO2 retainer with that high CO2, if you give them a lot of oxygen, those are the types that usually start hypoventilating and become lethargic and go unresponsive.
That pH gave it away.
Yeah, the pH gave it away.
I looked at the 86.
Yeah, I look at that.
All right, so
Simple one, got it.
with patients that have CO2 retention, they're better off with a venti mask because of the high flow. You're giving them the percentage that they need. Whether they have a period of apnea or if they have irregular breathing, you'll make sure that the FiO2 they're getting is more consistent. So yeah, venti mask for all CO2 retainers. And if you come across a scenario that mentions an irregular breathing pattern, if it says periods of apnea, venti mask. On your national exam also. Irregular breathing, CO2 retainer, you recommend a venti mask. All right, a 1.5 liter nasal cannula, that's equivalent to what percent oxygen?
25, 26.
26, about 26, right? 1 liter is 24%, 2 liters is 28, so probably 26%. All right, so if you put them on a venti mask, which percentage would you select?
The same. Would you put the same
28?
that you're giving in these cameras?
Could we go a little higher, maybe?
Yeah.
Get a stat at around 90%, maybe? So would 28% or 30% be okay?
30%.
All right, so we put her on a venti mask. Anything else? Do you think we should intubate and put her on a ventilator?
Some Ativan. He said she's gonna
What
No,
about
because
the
if we-
treatment? What about if she's having trouble, you know, if she's has an inhaler, then
Oh, yeah,
she's,
then she
let's say
can't.
she has COPD, so.
And you don't want to visualize your treatment later.
Okay, very good. What medication would you recommend?
Doing that?
Yeah.
Yeah.
Now, can you give back-to-back Duona?
Yes.
Oh,
No.
No, you can do that for albuterol.
Albuterol. So if she doesn't respond very well to your first treatment, could you then follow with a second albuterol treatment?
Yeah.
And what about if she still has severe shortness of breath? Is there anything else we could do to help her breathing without intubating her?
Not invasive. Position.
Oh yeah, position is really good too. And BiPAP? So that'll help her work her breathing. COPD patients respond pretty well to using BiPAP, as long as you can get the mask strapped to their face, because when they're really short of breath and you put the mask on their face, it's like a claustrophobic feeling. Sometimes it's good just to hold the mask there and let them have control over putting it on, taking it off, putting it on, until they get used to it, and then put the strap on.
What about a high flow nasal cannula? Would that help in this?
Yes,
I would-
yeah. Now, high flow is supposedly mild to moderate respiratory distress. So if she's got severe respiratory distress, that might be questionable. You'll probably see it done, but it's questionable when they have severe respiratory distress. A patient is intubated in the ICU for airway management post-intracranial hemorrhage. The patient's pupils are fixed and dilated. The heart rate, 156 per minute. Blood pressure, 80/56. Ventilator settings, PRVC. The rate is 18 per minute. Tidal volume 600 ml. FiO 2.3, PEEP is 5. Patient weighs 75 kilograms. And the ABG shows 7.58 pH, 22 CO2. PaO2 is 90. Bicarb is 22 with a +7 base. What would you do for this patient? How's that a +7 with a 22 bicarb?
Blood products? Blood products?
Lower the rate, get rate.
Blood products?
To increase the blood pressure?
Okay. Do you want to slow the heart rate down a little bit? Yeah, so the blood pressure might come up on its own if the heart rate's a little bit slower.
Okay.
Atropine, it makes the heart rate go faster. What about your beta blockers or your calcium channel blockers? Verapamil, is that something you hear given very often?
Is it?
calcium channel blocker, verapamil.
Yeah,
Mm-hmm. I
Yeah.
think I've seen that a couple times.
I've seen that a couple times.
So we have to lower that. Yeah, isn't the heart rate high because the blood pressure is low? Usually when it's low, it'll start beating more to compensate.
Yeah, that's possible. Having a damage to the brain, the vital signs are not controlled very well. You get a really fast heart rate, you get a really fast respiratory rate. So it could be that, it could just be that blood pressure is low. I don't see the heart rate going up to 156 just from a low blood pressure, but that is possible to have an increased heart rate with low blood pressure. And the pupils are fixed and dilated. So I would expect that there's not going to be spontaneous breathing,
Yeah.
Brain damage?
brain damage, yeah.
I see that. So when you get when you slow down the heart rate, will that help the blood pressure come back up?
Yes.
Okay. So give the calcium channel blocker,
Mm-hmm.
and then basically we have to correct the blood gas. So it's respiratory alkalosis.
All right, could they have been hyperventilating this patient on purpose because they want to
Yeah.
reduce perfusion to the brain and cause the intracranial pressures to go down?
Maybe.
Possibly, that's not recommended, but maybe that's what they were doing. So the rate was 18, tidal volume 600. What would we have to change it to get a normal pH with this patient? Oh, you have to use your handy dandy formula. All right, so it's minute ventilation on the ventilator. Does somebody have a calculator, 600 times 18?
Yeah. 10.8.
10.8 liters? All right, so 10.8 liters times the CO2. Where's the blood gas? CO2 of 22, so 10.8 times 22,
Divide by 40.
divide by 40.
So that's 5.9.
All right, so the new minute volume should be 5.9 liters. How do you want to go about getting 5.9 liters?
So
Can we keep the same tidal volume? 600 divided by the patient's, I guess we'll just use their weight since we don't have a height. So 600 divided by 75, what is that?
Is 8.
8? All right, so we can keep the tidal volume.
So you take the rate, 18 times.
No, don't take the rate of 18.
Sorry.
Take the minute volume
Yeah.
and divide by the tidal volume and see what rate you get.
Okay.
So the new,
Yeah, tidal volume,
So you want to read, it says 9.8.
9.3.
wait, you said minute,
9.3?
Yeah.
Yeah, 9.8.
minute volume divided by 600.
Yeah. Minute volume divide by tidal volume gives you respiratory rate.
10.
10?
Okay.
Yeah.
9.8.
All right, so we fixed this patient too. We're busy today. All right, here's an MBRC question. Permissive hypercapnia may be beneficial for a patient with which of the following? High plateau pressure, intracranial lesion, pulmonary hypertension, or head trauma?
C.
Yes, pulmonary hypertension. Wait a minute. No.
Pass the board.
Isn't it intracranial?
Hypercapnia?
That's not. What causes? It already causes it. What about intracranial?
No, when you have high CO2, that's not good for the brain.
So it's not B or D.
So it's not B. If you have pulmonary hypertension to begin with, and then you let the CO2s go higher, that makes the pulmonary hypertension worse. So it can't be C. If you have head trauma and you let your CO2s go really high, it's not good for the head. So it can't be D.
High plateau?
All right, so why, it's forcing us to consider A. See if you can find the connection. High plateau pressure. High plateau pressure means stiff lungs. And if you keep trying to ventilate with more pressure to get the CO2s down to normal, you end up damaging the lungs. So maybe we should just settle for the high CO2s instead of damaging the lungs to try to blow off more CO2. What do you think, Andrea? Does that fit?
It doesn't have to be up to like 7.2 pH or something. Like you increase the CO2 up to like a like I forgot
It's
what
in there,
range.
that's
I
pretty
forgot
good.
what range.
So with allowing CO2s to go high, it's okay as long as the pH stays above 7.2? Yes.
That's what I was going.
Yeah, very good.
I need a refresher, because I thought high CO2s, do they dilate the vessels in the brain, or do they constrict them? It constricts them.
It dilates the vessels in the brain. It's the opposite. Whatever it does to the pulmonary vessels, it does opposite in the brain.
Yeah, so it dilates
So,
the
So
vessels
it's
in
better
the
for
brain.
that trauma.
yeah.
No, because then you get a lot of bleeding and edema.
Oh, so you get edema. Oh, okay.
Okay.
Oh, I mean, I didn't know. Good function.
That is a good question, isn't it?
Yeah, I need a refresher. I thought I was right.
Oh, this last one. Okay, that ends our show.